Hey everybody, welcome back. Let's go through the cholinergic drugs and how they affect the ANS. So just as a reminder of the cholinergic receptors, M1 is going to be a muscarinic receptor. It's neuronal, so it's going to stay only in the brain, and it's a G protein coupled receptor, and it's going to use IP3 and DAG. This is excitatory. M2 is going to be inhibitory, and it's in the heart. It's also G coupled, G protein coupled, and M3 is going to be in the smooth muscle along with the vessels, and it's the same kind of path as M1. The nicotinic receptor is going to be in the muscle end plate, and it's an ionic, and the nicotinic neuronal receptors are once again in the neurons. It's in the autonomic ganglia, adrenal medulla, and they're both ionic. So the ionic receptors are going to work a lot faster. So here are the adrenergic receptors. Alpha, these are G protein receptors. Beta, they're also G protein coupled receptors. Alpha 1 are going to be in the blood vessels, the eye, and the smooth muscle of the bladder. Alpha 2 is going to be in the presynaptic neuronal membrane. It's important to note alpha 1 because there's a couple of drugs out there that's both alpha 1 and beta 2 blockers. Or beta 1 is going to be in the heart and kidney. Beta 2 is going to be in the respiratory tract, blood vessels, so like smooth muscles. Beta 3 is present in the adipocytes. You don't really need to know this one as much. It has less of a role in like regulation of the body. Okay, so alpha 1, when you stimulate them, they will vasoconstrict and dilate the pupil. They will also stimulate the bladder to contract. Alpha 2 is going to stimulate the parasympathetic system. It's going to decrease the release of norepinephrine and insulin. And they all work by decreasing CAMP, increasing IP3 in order to form contractions. So it's like one of the two. A2 will inhibit that, so there's no contraction. This norepinephrine will stimulate alpha 1, and then that's going to release the calcium from the IP3 pathway, and contraction occurs. Okay, so in beta 1, it's in the heart and kidneys, of course, to increase the cardiac output and increase renin secretion. And in beta 2, it's going to stimulate the smooth muscle dilation, so it's either in the lungs, GI, liver, or bladder. Liver, it will stimulate the conversion of fat to glucose. It's going to dilate the lungs and the vessels, and it's going to induce the relaxation. However, it's going to decrease urination. B3, once again, it's like lipolysis, so less with the blood pressure. Okay, so here's the important stuff. Direct action cholinergic drugs will act just like acetylcholine on the cholinergic receptors. So these are competitive, right? And they are acetylcholine, methylcholine, carbachone, and bethanachol. Bethanachol S is the important isomer that you have to pay attention to because it is much more potent than the R form. Why is that important? Because sometimes you don't actually want it to be potent. You actually want to give the less potent drug so you don't have the cholinergic drug adverse reactions. Other drugs are the cholinergic alkaloids, so these are going to be alkaline, and they're pilocarpine, aerocholine, and muscarine. Muscarine is really important. The acetylcholinesterases are going to be indirect acting because they increase the availability of acetylcholine by they're going to inhibit the acetylcholinesterase, and that's the enzyme that cleaves acetylcholine from the receptors and increases like the reuptake. So this is going to leave it in the receptors for a longer amount of time. So stigmines are going to be short-acting and reversible, so they're going to be physostigmine, you know that, neostigmine, pyridostigmine, and the only odd one is edrophonium. So stigmines are more important to remember. Irreversible are going to be your organophosphates. Okay, so when acetylcholine binds to M2 in the heart, it's going to decrease the contractility, the heart rate, and the amount of neuro or the synaptic firing, action potential. There we go. In the blood vessels, it's either vasodilation or vasoconstriction, depending on where it is. In the smooth muscle, they're also in M3. It's going to increase the peristalsis, bronchospasm, gland contraction. So there's more secretions of like saliva or tears or mucus. And in the eye, acetylcholine will bind to M3, and there's going to be the constriction of the ciliary muscle or the circular muscle. That's going to be the dominant receptor in the eye. There's a couple others, but this is the important one. Okay, so on the nicotinic receptors in the brain, on the autonomic ganglia, it's going to stimulate the sympathetic and the parasympathetic ganglia at high doses. So on low doses, it's only the sympathetics. In the muscles, it's going to produce contraction because of IP3. Okay, so acetylcholine will act on both the muscarinic and nicotinic receptors, and that will stimulate the acetylcholinesterase hydrolysis. Botanical is going to act on the muscarinic receptor to inhibit acetylcholinesterase, and that's used to treat ileus retention, urinary retention. So these are going to be used to like relax the smooth muscle. Which one was smooth muscle again? So that's going to be M2. Methacholine will act mostly on the muscarinic receptors, and it's going to inhibit acetylcholinesterase to treat asthma. And pilocarpine, cevimeline, these are also muscarinic receptors. They're going to inhibit the acetylcholine to treat xerostomia, so dry mouth, and glaucoma. So this is going to work in both M2 and M3 to decrease the intraocular pressure and to increase the glandular secretions. Okay, so alkaloids. Pilocarpine is made from a certain plant. They have effects on the eye because it can penetrate the cornea. So it's actually used to treat meiosis, ciliary muscle contraction, and fall in intraocular pressure. So it's used to treat only open-angle glaucoma, so not closed-angle, open. Cevimeline is going to be used to treat xerostomia, and you use it with the mydriatics to break or prevent the adhesions of the iris with the lens and cornea. And the adverse reaction of these drugs would be increased sweating, spasms, salivation, spasms from the M2 binding, and increased sweating is from the M3 receptors. Okay, so muscarine poisoning can occur in poisonous mushrooms. There is going to be all these kinds of mushrooms. Don't know if you have to really know them by heart, but just kind of know. You treat the mushroom poisoning with atropine. This is the life-saving drug. Except in the anticholinergic or like the hallucinogenic shrooms, that is when atropine is contraindicated. In late poisoning, it's also contraindicated. This is pretty rare though. It's only the phalloidin type peptide toxins, and that comes from the death cap mushroom. So unless you're really close to this particular mushroom, it's kind of rare. Okay, so to go back, the reversible anticholinesterases is going to end in stigmine. So there are all of these. Acridine or tacrine are going to be cerebroactive. This is important because these can also be used to treat like Alzheimer. Irreversible are cholinesterases come from insecticides, pesticides, and war gases. So tabun, serine, soman, carbamamates, carbamates. These are also irreversible, and those would be carbaryl and propoxyl. Okay, so what happens? Enzyme inhibitor will combine with acetylcholinesterase and prolongs that acetylcholine action. So the lipid-soluble agents, which are physostigmine and organophosphates, they have a strong muscarinic effect, and it affects the CNS, it stimulates the ganglia, and there's not going to be a lot of skeletal muscle action because it's going to be stimulating the smooth muscle. The lipid-insoluble agents, so neostigmine, pyridostigmine, edrophonium, have stronger effects on the skeletal muscle. So these do not have this cerebral or central nervous system effects. So these have certain roles that you have to pay attention to. Okay, so in the ganglia, the acetylcholinesterases will stimulate the ganglia, and in high doses, it causes persistent depolarization of the ganglionic nicotinic receptors, and they block transmission, leading to flaccid paralysis. In the cardiovascular system, in the muscarinic action would be bradycardia and hypotension. Ganglionic stimulation is going to increase the blood pressure. Stimulation of the medulla is going to depress the respiratory system. And the muscles, there's going to be spastic paralysis because of the persistent depolarization. Okay, so we use it in the eye to counteract the effects of mydriatics after refraction testing. So we dry out the eye. Prevents the formation of adhesions, once again, between the lens, iris, and cornea. In myasthenia gravis, pyristigmine or neostigmine is going to block the muscarinic atropine. And post-operation, it's used to treat paralytic ileus and urinary retention to, not contract, but to relax them. And post-operation decurarization, so it's going to counteract the effects of curare. It's going to reverse that skeletal muscle reaction. It's also used to treat cobra bites. You use neostigmine along with atropine. And in belladonna poisoning, you're going to treat using physostigmine. And in Alzheimer, tacrine, rivastigmine, and donepezil. Okay, organophosphates. They're lipid soluble, so unfortunately they can be absorbed through the skin, the mucosa, and the lungs. And they're going to have all these effects. The important ones is diarrhea, because that is going to be a loss of bicarbonate, so it's going to result in acidosis. Bronchospasms, reduction in breathing, bradycardia, low BP, excessive salivation, losing liquids, sweating, losing liquids and electrolytes, and cooling down the body temperature. This can lead to shock. Nicotinic affects the muscle fasciculations, tremors, weakness, and the paralysis. We got to be very careful for. In the CNS, there's going to be agitation, seizures, and coma. And ultimately, death comes from the respiratory paralysis. So how do we treat this? We give them the activated charcoal, and you give them atropine to really treat. Pralidoxim is going to be used after giving atropine, having that work to reactivate the enzymes. Okay, so atropine, what does it do? It's a muscarinic receptor antagonist. You can give it IV, and it's going to increase the heart rate. It's going to reduce the bowel sound, so it's a sympathetic agonist, right? Dry the mouth, decrease the bronchial secretion. And when the eyes start getting dilated, that's a sign to stop the administration. Because remember, atropine in high doses, it can actually activate the parasympathetics. Pralidoxim is used to reactivate acetylcholinesterase. It binds to the organophosphate molecule, and the organophosphate bond to the acetylcholinesterase is broken, and it's going to allow the organophosphate to be excreted. So it's reserved for the potentially fatal cases. It's unfortunately not going to help in carbamate poisoning. Okay, Myasthenia gravis is going to be autoantibodies against the nicotinic muscular receptors. It's a muscle weakness that recovers with rest. So the test is the blinking. So you ask your patient to blink fast for like 30 seconds to a minute. For a normal person, you can keep blinking, but with somebody with myasthenia gravis, depending on how bad it is, usually around 10 seconds, they're already struggling. It's harder and harder to open their eyes. So you treat them by giving them the neostigmine, and if a muscarinic side effect occur, you give them atropine. You can also give them pyridostigmine, and then you also give them the corticosteroids. Strangely enough, doing a complete thymectomy will solve myasthenia. It will cure myasthenia gravis in a good chunk of the population. And then after all this, you use the plasmapheresis to remove the antibodies. Okay, what's a cholinergic crisis? That's going to be muscle weakness due to overdosing with the anticholinesterase. So, giving the hydrophonium test, if you give them the medication IV, there's going to be improvement. That's going to be a sign of myasthenia gravis. If it worsens, it's going to be a cholinergic crisis. There's something called a tubocurarine test, but it's really hardly used anymore. It worsens the symptoms of the cholinergic crisis, so it's contraindicated. Instead, we use the antibody test. So here we go. You use the assays, and then see if it's going to be an acetylcholinesterase inhibition, and you really do some like testing and like CT stuff like that. But the fastest test is just to do the blink test. Okay, so nicotine is a ganglionic stimulator, and it will blockade. It will force the neuromuscular end plate to depolarize. So the stimulation following the depolarizing blockade is going to lead to the flaccid paralysis. No acetylcholine is going through. There is CNS toxicity, so it's going to have stimulation, convulsion, and then all of a sudden depression of all the symptoms. And varenicline is going to be used as the nicotine transdermal patch because it's an agonist. Bupropion is a norepinephrine or dopamine reuptake inhibitor. So that's also used to treat nicotine addiction. That's it for now. Thank you for your attention, and good luck studying.